So let's look at a few cases here. These are some patients I'm actively working with right now. So it means I have some preliminary results, but we don't have ultimate answers here. For me, ultimate answer has three components: subjective improvement, objective improvement, and long-term, durability. And so we're still working on that. But at least I can show you how to initially work these patients up, at least from a nutrition functional medicine, what I call nutritional immunomodulation protocol. So we've got a 34-year-old Hispanic male with psoriasis, rheumatoid arthritis, and Hashimoto's thyroiditis. We've got a 51-year-old white female with severe aggressive drug-resistant rheumatoid arthritis. Let's look at the young man first. He's a 34-year-old Hispanic male who presents with possible psoriatic arthritis. So I'm not really fond of possible. I like to be definitive. So he's had several years of debilitating joint pain. Additional complaints include fatigue. He's overweight. He also has lack of energy and low libido. He saw a dermatologist here in the U.S. who described him as having a classic psoriatic flare following exposure to penicillin for a prophylaxis for a dental procedure. So does that provide us any data as to what's going on with this guy? Like for me, that's payoff, right? So the fact that he had a psoriatic flare following the administration of penicillin, basically what he was having was what we call a Herxheimer reaction. So what happens, and what happened in his case, so everybody know what the Herxheimer reaction is? Die-off reaction. So it's called the Herxheimer reaction or the Jarvis-Herxheimer reaction, classically described in patients who have syphilis who are treated with penicillin. They would get worse before they would get better. So sometimes it's more commonly referred to as a die-off reaction. And so on a molecular level or microbiologic level, what's happening is when microbes are exposed to antibiotics, they either produce more toxins in some cases, or they're just dying off and they're releasing their cellular contents, like in terms of for gram-negative bacteria, it would be endotoxin, lipopolysaccharide. For gram-positive bacteria, it's exotoxin or teichoic acid. For all bacteria, whether gram-negative or gram-positive, it would be bacterial DNA. So they're releasing all of this inflammatory debris, as I call it, microbial debris. The immune system has to deal with and respond to that. That's why you see these patients get worse, right? Does that make sense? So we call that a Herxheimer reaction or a die-off reaction. So this guy had a classic psoriatic flare as diagnosed by his dermatologist following a single dose of penicillin. So what happened? He took the penicillin, it killed off some of his group A strep in his throat, most likely. He had an immune response to the bacteria that caused him to have a psoriatic flare because his immune system then was responding to the amino acid profile of the group A beta hemolytic strep, which was cross-reacting with antibodies targeting his keratin 17. So in my opinion, that's what happened. So I said, great. That's what I want to hear. He saw two rheumatologists in the U.S. who were uncertain, they said, of the exact diagnosis. Does that make me? That does not make me happy. You already know the answer. I think if people are getting paid $400 an hour for a consult, they need to be able to make a commitment and step up. So despite the fact that they couldn't diagnose him, of course, they drugged him, and he did have a positive response to prednisone. They recommended that he start one of the biologic drugs called Remicade, infliximab. So all biologic drugs, as I talked with someone a few minutes ago, all the biologic drugs are what we call anti-tumor necrosis factor alpha drugs. Sometimes it's what's called a soluble receptor, so the drug might be like a sponge that goes in the bloodstream and soaks up all the tumor necrosis factor alpha, or it might be, for example, like a mouse antibody against TNF alpha. But basically it's some way to neutralize, absorb, or inhibit tumor necrosis factor alpha. That's what the biologic drugs are as a group. And if you think about it from a marketing standpoint, it's even more brilliant because biologic means the logic of life, and so you're actually encouraging doctors to be consistent with the logic of life by using these drugs that cost $50,000 a year. So I think it's some kind of a marketing scheme. I mean, why are these drugs called biologics? It doesn't make any sense to me. He saw two doctors in Mexico. They prescribed him the usual gamut that I reviewed previously of anti-inflammatory drugs, and they did some tests on him. They found that he was CCP positive and RF positive, and that they actually did a urine culture on him and found that he had Proteus, Great. Great work. And I'm being serious when I say that. They did some quality work. So the fact that he's CCP positive, what does that tell us? With a clinical picture of joint pain, he's got rheumatoid arthritis. So he's clinically, if you look at him clinically and if you look at his CCP antibodies, it would be very reasonable to say this guy's got rheumatoid arthritis. And what happens if he has joint pain and a positive rheumatoid factor? Could we diagnose him with rheumatoid arthritis based on that, assuming that the pattern is consistent, like peripheral inflammatory symmetric polyarticular arthritis? Could we say that he's got rheumatoid arthritis? Sure. So if he's got positive CCP and positive RF, what do we call that? That's called conjugate seropositivity. So that means if you take that and in association with his clinical picture, this guy's got severe aggressive rheumatoid arthritis. That's the answer. So why his 2 U.S. rheumatologists couldn't come up with that when it's obvious, I think is not impressing me. And they did a urine culture and showed they had Proteus. And I mentioned Proteus earlier, associated with rheumatoid arthritis, right? Boom, we're already on the trail here. So let's keep going. Physical exam, he's got this one psoriatic patch behind his ear. I didn't see anything else. He's got a body mass index of 42. So he is very severely obese, morbid obesity, and he's hypertensive. Okay, so there's your patient. What are you going to do about it? Right? So, according to what we're reviewing and learning here, we would go through our usual SOAP note, which is basically what I have here: subjective, objective, assessment, and plan. So, what's our assessment? Fatigue, psoriasis, rheumatoid arthritis, obesity, hypertension. That's a pretty good start. So, could we treat him with the protocol that I've discussed so far? So what are the 7 components of that protocol? So the acronym is what? Find sex, right? F-I-N-D-S-E-X. So you write that down. You've got your memory tool there, and you just fill in the blanks. So what does F stand for? Food. So we do the 5-part protocol. Paleo diet: fruits, vegetables, nuts, seeds, berries, lean sources of protein, avoid allergens. Modify potassium intake for people with kidney insufficiency, right? There's F. I, we have to look for dysbiosis and chronic infection. So we're not simply looking for microbes, but we could certainly think in terms of microbes, but we also want to think in terms of antimicrobial. So the 3 components of I are antimicrobials, immunorestoration, and the induction of immune tolerance, which we do through nutritional immunomodulation, which is step number 3. So N stands for nutritional immunomodulation. How many components? 6 components, right? You could add a 7 if you want to use the antibiotic that I mentioned before for the segmented filamentous bacteria. So what are the 6 components of nutritional immunomodulation? Vitamin A, vitamin D, lipoic acid, green tea, omega-3 fatty acids, and probiotics. Right? Some of those are already covered in the 5-part protocol, right? Vitamin D, omega-3 fatty acids, and probiotics, we've already covered them. So all we're adding is lipoic acid, vitamin A, and green tea. So then we get to D, which is dysfunctional mitochondria. So we're going to put him on a low-carb diet. We're going to have him exercise. We're going to use CoQ10, and we're going to use lipoic acid and acetylcarnitine. Why would we use acetylcarnitine and lipoic acid in this guy? We would use acetylcarnitine in him maybe because it helps to improve sexual function in men. He's complaining of low libido. It helps people to lose weight. It helps to lower blood pressure. It helps to improve insulin sensitivity. Lipoic acid, we would use that in him because he's already got a inflammatory condition, right? We're using the lipoic acid as part of the immunomodulation protocol. But another reason to use lipoic acid in him would be that it has a effect of improving hypertension, and he's hypertensive. So we've got 2 reasons to use that. CoQ10 lowers blood pressure, it lowers blood sugar, so it improves his hypertension. His hypertension is definitely worth treating. It's at 145/95. So we should treat that. So we've taken care of his mitochondria. So S stands for sleep, sociology, things like that. He has a very positive relationship with his wife, so I don't have any concerns there. I think he gets sufficient sleep, so I'm not picking up a lot of things I need to work on there. And he's a really pleasant man to work with. So I think we've covered, I think his base is covered there. E stands for endocrinology. How do we treat his hormone imbalances empirically? The answer is we don't, which means we have to test his hormones. So then the question becomes, what are we going to test? And it's the ones I already told you about. Prolactin, estradiol, cortisol, DHEA, and testosterone. And insulin one way or another. So we'll look at some of those results here in a minute too. And then the final step, xenobiotics for the X. It'd be nice to have him on some type of detox protocol, but I don't push the entire protocol to completion in every patient. And in his case, I'm going to lighten up on that one because I've got him taking so much, he's already kind of at capacity. So here are his lab results, and you can see that the date on these is May of this year. So remember, we're looking for a pattern in him. So in order to look for that pattern and identify which components are applicable to this young man, we have to ask the right questions, and that's basically what we do with lab tests. So ordering lab tests is basically your way of saying, I don't know what's going on here exactly, let's ask the question and figure it out. So we look by asking these questions. We look at his testosterone, and you don't have to know anything about endocrinology to know how to interpret this test. His testosterone's low. That's one of the components I was looking for. He's got antithyroid antibodies, so he's got thyroid autoimmunity, so he already won the Hashimoto's thyroiditis award. His glucose is acceptable, but I think he's got slight insulin resistance. Not too bad, not too bad. Slight elevation in TSH. TSH shouldn't be higher than 3, and he's at 3.5. So he's his gland is starting to fail. His estradiol level is 28. I think that's a little high, but it's particularly high if you look at his low testosterone, right? So when we think of androgens and estrogens, we have to think of them in working kind of in concert or in ratio. And if you look at a low testosterone with a slightly high estrogen, his ratio is not perfect, or his balance isn't perfect. Look at his vitamin D level. So he lives in the southern United States, and his vitamin D level is 19. Optimal range is what? 50 to 100, so he's low. So on one lab result, I got 6 actionable items. I tested him for celiac with antitransglutaminase. I just did the IgA. Probably okay. So I can't stamp him with celiac disease, but he could have selective secretory IgA deficiency. I'm just not sure yet. Thyroid hormone, I prescribed him some thyroid hormone because he was fatigued and he had some thyroid autoimmunity. So I put him on prescription T3. And we can talk about that more later. So when I look for thyroid status in patients, I assess them by history, physical exam, and labs. So what's the history of a patient who has hypothyroidism? I mean, there are a lot of different things that can come up. Usually it's kind of a generic cluster of problems, right? Fatigue, depression, cold hands and feet, dry skin, constipation. That's what you hear most often. And so those are the questions I ask. When I'm starting to think hypothyroid, I ask patients, I say, look, I'm going to ask you a list of questions. Let me know if any of these apply to you. Do you ever feel fatigued? Do you ever feel depressed? Do you ever get cold hands and feet? Do you get dry skin, constipation? Do you get little red bumps on the back of your arms? Otherwise known as follicular hyperkeratosis, otherwise known as a sign of vitamin A deficiency, otherwise a manifestation of their inability to cleave beta-carotene into vitamin A, which is a thyroid hormone-dependent process. So those are the questions I ask, and after that we move on. Physical exam. What's physical exam for a hypothyroid patient? There are a couple things that you look for. I mean, you can look for lots of different things, but let's focus on what's specific for hypothyroidism. Some people will say thinning of the lateral third of the eyebrows over here. So if their eyebrows get really thin over here, that actually has a name associated with it, and it's considered to be a suggestive sign of hypothyroidism. Great. I'm not going to make a diagnosis based on that. What I look for is relative or absolute bradycardia. So bradycardia is defined as a heart rate less than 60 beats per minute. But if I'm dealing with someone who's not athletic and their heart rate is like 65 beats per minute, then I'm giving them a label of what I call relative bradycardia. Their heart rate is too low for their cardiovascular fitness level. So I look for bradycardia. I look for what's called delayed Achilles reflex return. And it is what I just described. It's delayed Achilles reflex return. So you test their reflex. When you're measuring reflexes, typically what you're looking for is the contractile component of the reflex, right? That's what tells you if their nervous system is intact, right? So you hit the reflex, you're looking for them to be somewhere between 0 and 4, and hopefully they come out at 2, right? Because 2 is normal. So independent from that, what you're looking for in hypothyroid patients is what we call reflex return or reflex relaxation. And so after you've hit the reflex and their foot goes down, you want to assess how quickly it goes back up. Because remember, is that right? You've got your finger under their foot, right? You tap the reflex, the foot's going to go down. You want to see how quickly that muscle relaxes, because that's a sign of thyroid function. And if you look in a textbook by, like the one from DeGowan and DeGowan, Bedside Diagnosis, they say in that book that a delayed Achilles reflex return is diagnostic of, or indicates in their language, indicates hypothyroidism. So you could reasonably make a diagnosis based on that clinical finding. So what would you do with the diagnosis? Then you'd have to select your patient and see if they're appropriate for a thyroid replacement. So anyway, what else do you look for? The other thing I look for on physical exam is cold hands and feet. So what are 3 conditions that lead to cold hands and feet? Number 1, low metabolic rate, otherwise known as hypothyroidism if it's an appropriate clinical condition, unless the patient's like 100 years old. So low metabolic rate, cold hands and feet. Peripheral vascular disease, you can figure that out by a physical exam because you find other things, right? And Raynaud's syndrome, I'm throwing that in there just for the sake of kicks, but it's not really appropriate because it's intermittent, right? So if they're always cold, if they always have cold hands and feet, it's either hypometabolism, otherwise known as probable hypothyroidism, or peripheral vascular disease, or maybe Raynaud's, but beyond that, I'm not coming up with much. So after that, we go to labs. And the question isn't which lab should we do, the question is we should do all the labs. So what are all the labs? TSH, free T4, total T3, reverse T3, and antithyroid antibodies, right? If you're going to look for the problem, I think it's best for all of us if we look all the way. No point in asking half a question unless we don't want to see the answer, right? So that's how I assess thyroid function. You'll notice his ferritin is 234. That's a little bit high, but I'm not worried about it because we have to focus on what's important. He's not going to die of hemochromatosis with a ferritin of 234. Not too worried about that. And I've published a lot on iron overload too. In fact, my first research articles were published on iron overload, so I'm pretty confident with that. What's his urine pH? 5.5. What do we want to do about that? So is that okay?